Good morning, friends. Welcome once again to the teleconferencing sessions. Now you have finished your theory examination. The results of the theory examinations are likely to be announced by the end of February. So the board has decided all the teleconferencing sessions for the month of February will be focusing on final year students who are going to appear for their practical examination. So in that context, all the sessions which we are having in the month of February will be giving you important hints how to prepare for your practical examination. Here again we would like to emphasize that when you are preparing for your practical examination, it is important that you form in your department, respective department, DNB clubs. Because in adult learning situation, more efforts are required from your side, and we have seen that in the examination, if you have good confidence and communication skills, you are likely to score better. So in that context, it is important that you form DNB clubs in each of departments, and then you make case presentation to each other, because communication skills are very important. The way you take the history, the way you take the clinical examination, the way you discuss the differential diagnosis and management is very important. So unless you have the practice beforehand in terms of presenting case among yourself and then to your consultant, in the examination you will find it difficult otherwise. So I will request all the DNB candidates who are going to take their practical examination to form these clubs and start making preparation for the final practical examination. Here again I will like to mention, as per the current guidelines, in the practical examination we have the clinical component and we have the viva component. The student is expected to pass both the component by securing 50% of the marks. In the practical component you have long case, you have short case, you have ward rounds, and also the instrument and the viva component. So it is important that you start preparing case wise, like long cases, short cases, what are the important long cases in various specialties which are likely to put in the examination. The tentative list of these cases have been given in the revised curriculum, which is already on the website. So again I will request you, please download from the curriculum the important cases which are likely to be kept in the examination. And again it is important that when you are making a presentation among yourself, please don't ignore the important key points which are important from your diagnosis or approach to the patient. So important key points in history, clinical examination, what are the important differential diagnosis, and what are the important investigation, and how you have to discuss the final management with your examiner. Some of these key points are already put on the website. So please download these key points for some of these important case discussion. During this teleconferencing session which we have scheduled for the month of February, we are going to cover major 10 specialties. So today we are going to take the specialty of gynae and obstetrics. On 13th, which is tomorrow, we are going to cover surgery. Then on 14th we are going to cover radiology in the forenoon from 11 to 1:45. On 19th from 11 to 4:30 p.m. we are going to cover the discipline of medicine. On 20th, we are going to cover in the forenoon session from 11 to 1:45 ophthalmology and 2:30 to 4:30 ENT specialty. Similarly, on 22nd, from 11 o'clock to 4:30 p.m., we are going to cover pediatrics, and on 26th, from 11 to 4:30 p.m. we are going to cover the specialty of orthopedics. So this is our tentative plan. So don't miss these sessions. The experts here which are going to be very, very important for you in terms of giving you practical hints. And again I will like to remind you, these sessions will not substitute your regular preparation. So please start making plans for your case presentation by forming DNB clubs. As you know, we have been receiving lot of requests from the DNB candidates. They want to get the recording of the previous DVDs, teleconferencing sessions. So these DVDs are now likely to be available. So from the website, please download the format and you can order this DVD to us. The last date for reception of these orders is 15th of February. So I request all the institutions, they should have a set of these DVDs, because these interactive sessions are going to be very useful for the students. So you have a set for your library, and if the student wants to have their individual copies, they can also write to us as per the format which is on the website. There is another information which I want to give to the students, especially those who are going to appear for the surgery practical examination. The board has organized a CME program, 3 days CME program in the specialty of surgery from 16th, 17th and 18th February at Safdarjung Hospital, New Delhi. This notice is also on the website. So I request all the exam going DNB students, especially those are in the final year or second year, if they attend this CME program, again that will give them very useful hints for preparing for helping them in preparing in the practical examination. So we are also planning some of these CME program in major specialty on regional basis, and this information will be conveyed to you on the website. So please look into the website very regularly. So today we now begin with the today's session. Today we are, as I said, we are going to cover the specialty of gynae and obs, and here we are going to cover in the morning session, that is the current session, which is from 11 to 11:45, we are going to cover history taking in a gynae and obstetric case. It is very important how you take a history in a case. And then we'll have a break for 15 minutes, and the next session from 12 to 12:45 we'll be telling you important hints for clinical examination of a obstetric case. This will be followed by the clinical examination of a gynae case. Then after lunch from 2:30 to 3:15 we are going to cover another important area, because in a practical examination sometime during your viva you are asked about the applied aspect of anatomy and physiology as applicable to gynae and obstetrics. So our experts will give you some important hints what are the important applied aspects of anatomy and physiology, and this session will be followed by pre and post operative care of a patient, especially in certain gynae and obstetric operation. So I request that today's session is very important. So once again I request the institutions and the concerned DNB coordinators to allow their DNB candidates to take up this, to attend this particular session. So we begin with the first session, and let me introduce the expert who is available with us. To my right is Professor Uma Goel. She has been the former director, professor and head of department of gynae and obstetrics, and she was also the vice principal of Lady Hardinge Medical College. She has vast experience. She has been involved with PG teaching for more than 20 years. Welcome, madam, to the studio. And she is going to help you in giving very important hints how to take a history for a gynae case, OBG case. This is very important. So to my left, I have Dr. Ashwini Agarwal. He is Assistant Medical Executive with the National Board of Examination, and he will be helping you I think in various teleconferencing programs. So I request now Professor Uma Goel to take over and tell our candidates what are the important points they should keep in mind when they are taking history from the patient.
Good morning, students. I am going to tell you about history taking in gynae obstetrics. Before I start proper history, let me tell you what is gynecology. Gynecology deals with diseases of female genital tract, while obstetrics deals with pregnancy and pregnancy related complications. Therefore, when a female patient comes to you, anxiety is generated between you and the female patient, that because of the sensitive nature of the problem, that how you are going to deal with her. In this connection, and why history is important in a clinical case to make a correct diagnosis, history is important. There are two main components to make a clinical diagnosis, be it a gynae case or obstetrics. History makes a foundation, or history lays a foundation stone of the diagnosis, which is complemented by examination. Next, meticulous history taking alone can lead to positive provisional diagnosis in majority of the cases. Therefore, again there is a lot of stress on history taking. Next, principle of history taking are that first of all, make the patient comfortable. Ask her to sit by side of you on a stool or chair. Use simple language so that she can understand what you're asking. Suppose she is not able to understand your language, or you are not understand her language, then ask someone to help out so that she can explain her problem in her language. Use simple words in local language. Counsel her about that you are going to ask her question, because it will lead to make her correct diagnosis and treatment can be constituted. Make privacy so that she is comfortable in telling her complaint. You have to listen to her carefully, because she is going to narrate her history. she should not feel that you are disinterested or you are not listening patiently. Next. In gynae case, basic informations are important, be it gynae or any other clinical case. In this basic information, we start with registration number. Registration is important because all the case must be registered in a register or in computer. These days is a computer era. All the basic information should be registered in the computer because we can trace the previous records if required. This basic information includes registration number, date and time, name, her husband's name, or if she is unmarried, her father's name, detailed address, telephone number, and in case of emergency, whom to contact. This is a basic information which should be available with either in the register or in the computer. Next is a demographic profile which includes age, marital status, parity, occupation, socioeconomic status, and what is her residence. The importance of age is very important because there are certain problems related to age, like if she is 14 years and has not started her periods, one can say that there is a slight delay in onset of puberty. But if she is 20 years of age and has not started her period, it will be diagnosed as primary amenorrhea. Similarly, if she is 35 years of age and she is not conceived, it will be that called as primary infertility. Marital status, whether she is married or she is unmarried. If she is married, there are certain problems which are related to reproductive tract. The repeated pregnancy or abortion can lead to infection commonly, while if she is unmarried, increased incidence of uterine malignancy. Occupation as such does not have much bearing, but certain occupations do have occupational hazards. Socioeconomic status again is important because in poor socioeconomic status, the common diseases are anemia, which leads to various types of infection, while in the upper class it is obesity and hypertension which are common. Where she resides is again important. In rural area, as I said, poor socioeconomic class lives, and infection and anemia are very common. Next. And ask the patient to describe her main complaints in her own words. Let her take her own time in describe the events of problem, any other problem associated with it, and aggravating and relieving factor. All these complaints should be jotted down in chronological order. In history, first of all, since when the problem has started, what was the point or place in where the problem has started, what is the total duration of the problem, how the disease has progressed, what are the aggravating and relieving factors, and is there any relationship with menses, urination or defecation. Now, how it is important, because I give you common example of common gynecological complaints are like pain in lower abdomen and lower backache, vaginal discharges, menstrual complaints, infertility, something coming out of vulva, lump in lower abdomen, and malignancy. These are in order of frequency. Pain in lower abdomen and vaginal discharge constitute about 50 to 60% of gynecological cases, while menstrual disorders are 20 to 25%. Incidence of infertility is 10 to 15%. Something coming out of vulva, lump in abdomen and malignancy constitute about 10 to 20% of cases. You have to ask, I give an example that you have to ask, if she is saying that she has got pain in abdomen since last 1 year, but since last 2 months she has got discharge also. This pain goes to back also, and she is very uncomfortable when she urinates. But she gets relieved when she passes urine. Again the pain gets aggravated just before menses and lasts for 12 to 14 hours. And that as the menses progress, she is relieved of her pains. These all indicate that there is some infection in the lower genital tract. That means it could be a case of chronic PID. Next. In the history of menstrual history, which is very important, age of onset of menarche. Menarche means first period when she had. Usually the normal age of menarche is 10 to 12 years. If she had a period early, it is called precocious puberty, or if she had period after 14 years, it is called delayed menarche. Length of cycle means that first day of cycle to first day of next cycle. It is normally 28 to 30 days, but it can be extended to 35 days. Any cycle shorter than 21 days or longer than 35 days is abnormal. Amount of blood loss. Normal amount of blood loss in a given cycle is 50 to 80 ml. Any presence of clots means excessive blood loss. Excessive blood loss is called menorrhagia. Next is primary dysmenorrhea or secondary dysmenorrhea. Patient has pain with the onset of menses and gets relieved within 12 to 24 hours is called primary dysmenorrhea, which can be so severe that she has to miss her work or her school or her college. But it is usually relieved with analgesics. While if she has secondary dysmenorrhea, the causes are different, that it could be endometriosis or adenomyosis. Then is when she had her last menstrual period. This is important to note, that when she had her last period. Next please. Now there are few words which one should know in menstrual history. That one is amenorrhea. Amenorrhea means there is no menses. As I told you earlier, this can be physiological or pathological. In physiological, before puberty is amenorrhea. During pregnancy of 9 months, there is no menses, it is amenorrhea. And after menopause, when cessation of menses occurs between 48 to 50 years, it is again amenorrhea. These are the physiological condition of amenorrhea. But pathological conditions are when there is no periods without due to certain diseases. It is called pathological amenorrhea. Like in cases of hypothyroidism, there can be amenorrhea, or in tubercular endometritis, there can be amenorrhea. Then is oligomenorrhea. Oligomenorrhea is when bleeding is very less and lasts for 1 day, or small amount of spotting lasting for 1 to 3 days. This is oligomenorrhea. It is again common in cases of hyperthyroidism or tuberculosis. Then is menorrhagia. Menorrhagia means excessive amount of blood loss, but the cycles are normal. This is common in case of pelvic inflammatory diseases. Polymenorrhagia. Polymenorrhagia, there is excess amount of blood loss, plus cycles are shortened. As I told you, the normal cycle is 28 to 30 days. It becomes to 21 days. But cycles are regular, but there is excessive bleeding for 5 to 7 days, and she may be passing clots. Then is metrorrhagia. Metrorrhagia means that there is no cyclical pattern is maintained at all. She has bleeding irrespective of cycles after 5 days, after 7 days, and this bleeding is continuous for 10 to 15 days. Then is postmenopausal bleeding. Again is an important term, postmenopausal bleeding, because when menses has ceased or stopped for a year at the age of 50, and suddenly at age 52 or 55 she noticed that periods have again started, it is pathological. And in this cases, one should rule out malignancy always of genital tract, especially ovarian and uterine malignancy. Next is marital history. How long she has been married. It is very important, especially in cases of infertility. In India, girls get married at a very early age, and there is a ritual that when she attains puberty, they are sent to her husband. But as she reaches to her husband's house, her mother-in-law bring her to the gynae OPD saying that she is infertile, while she has stayed with her husband only for a few months. So, as I told you earlier, age and next, how long she has been staying with her husband is important, because till she is at least stayed for a year with her husband and not conceived, only then it will be infertility. Dyspareunia is a term when there is a difficulty in coitus, when it could be physiological, it could be pathological. Physiological is that when she is unable to relax, or pathological is when there is a vaginal stenosis because of previous repair of the perineum. Next is past history. Past history of tuberculosis is very important. Again, in the case of infertility, as I told you, the infection in genital tuberculosis, the common site is inner lining of the tube, that is called endosalpingitis, and which causes straightening, hardening of the tube, and hence conception does not occur. Thyroid disorders, especially hypothyroidism, which is associated various types of problem, including infertility and oligomenorrhea. Diabetes is again responsible for diseases like menorrhagia or recurrent abortions, or maybe that it causes one of the contributory factors for endometrial carcinoma. Any other surgical intervention, if she had, should be known. Next is family history. In family history, again, history of hypertension. If there is a history of hypertension in mother, she is likely to get hypertensive in later life. History of obesity, diabetes, tuberculosis, as I have explained to you, is also important. Now, tuberculosis in the family is only when it is open tuberculosis. Otherwise, as such, other types of tuberculosis are not carried out to the other family members. This you must note, that genital tuberculosis is not which can be carried out to the other siblings. Next, obstetric history. In obstetric history is parity. Parity means that how many times she has conceived and carried pregnancy up to the viable state. That is called parity. Then number of children, number of living children she has, and number of children died during pregnancy, delivery or afterwards. Then number of full-term pregnancy or preterm labor, number of abortion, whether it was spontaneous or it was induced. Next is dietetic history. In diet, you must ask what type of diet she is taking, especially in poor socioeconomic status. They are anemic and they are prone to infection. Any addiction like tobacco or tobacco chewing or smoking, one must note. Is she allergic to any medicine, or in past she has any allergic reaction to any medicine, should be noted down. Now to sum up a gynae case, as we start from basic to the all headings which I have just narrated to you. Let's suppose a case of pain in abdomen has come to you, pain in abdomen, lower backache and vaginal discharge has come to you. Ask them since when it is, what is the aggravating and relieving factor, relation to menstruation. So you are able to make a positive provisional diagnosis only on the basis of history. So history taking, give patient listening to the patient so that she can tell you in detail about her problems. Now I am coming to obstetric case. The basic information remains the same. Now I will not repeat, but we switch on to demographic profile. With demographic profile, as age was important for gynae case, similarly age is important in the obstetric case also. But at times, especially illiterate women do not remember their age. Then you have to do some guesswork like asking how many children she has, how old they are, and how is the little one, how old is the little one. And depending on age, there are certain problems. Like in cases of first pregnancy, at the age of 14 or 15 years, it is called teenage pregnancy, while pregnancy beyond 35 weeks is 35 years is called elderly primary. Both are high risk pregnancy. As I told you that in India the girls get married early, and by the time of 18 years they are mother of 2 or 3 children, especially in poor socio-economic status and especially in rural area or urban slums. Gravida. Gravida means that number of times she is pregnant. It includes from the time of conception to the time of termination of pregnancy. That is called gravidity. Para means number of time she has viable pregnancy and delivery. Abortion means that she has conceived but aborted before the viability. Then number of living children. Out of viable pregnancy, how many children are living and how many are dead. Then is what is her occupation. Occupation again is important because if they are doing manual work, it may lead to premature labor or repeated abortion. In socio-economic status, again, one has to see that usually these ladies are anemic and they are more prone to infection. Next. In menstrual history, one has to ask about the menarche and cycles I have already discussed, about last menstrual period. Because one wants to know at what is the age of total pregnancy when she has reported to you. So knowing last menstrual period is again important, for which again she is not sure when she has her last period. In that case, you should be conversant with the Hindi calendar also, with the festival dates also, and with the with both the things, so that it doesn't look that you are ignorant about the Hindi calendar or dates of festival. She'll say it was near Diwali, last period was somewhere near Diwali, or it was just before Holi when she had. So just see the calendar and then get a date. Then one has to calculate the expected date of delivery. In calculating the expected date of delivery, one should see, one should add 9 months plus 7 days. While if you are or 10 lunar months, when the date is not available at all and she is not able to tell you about the festival date also, then one can ask when she felt quickening. Quickening is first kick of the baby. This first kick of the baby is appreciated early in cases of multigravida, but in cases of primary, it is appreciated a little late. In cases of multi, it is about 16 to 18 weeks of pregnancy when she feels for first kick. While in cases of primary, it may be 18 to 20 weeks. Then comes to the proper history. Chief complaints in a pregnant woman are amenorrhea, and along with amenorrhea there can be vomiting, breathlessness, palpitation, swelling. These may be normal or abnormal. To take an obstetric history, it is better to take the, again for in obstetric history, the complaint should be in chronological order, and to take obstetric history, one can divide it trimester wise, first trimester, second trimester or third trimester, or one can take as first half of the trimester or second half of the trimester. Both the things are all right. If you take trimester wise, there is slight overlapping in the trimester wise history, but if you take first half of the pregnancy or second half of the pregnancy and can take all the points, it is all right. Now first trimester or first half, I have taken first half of the pregnancy. Amenorrhea is first and foremost complaint. The amenorrhea is of 5 months. Then there is a history of vomiting. Now if she gives history of vomiting at amenorrhea of 5 months, it is not normal. But if she is amenorrhea of 2.5 months and she gives history of vomiting, it is normal. In the first trimester, there is a history of vomiting, history of nausea, history of wayward appetite. These are the common symptoms. Again, history of frequency of micturition and history of heaviness of breast. The causes of nausea and vomiting, that she feels nausea when she gets up, she is unable to eat anything, she vomits once or twice. This is absolutely normal in first trimester. Wayward appetite means that she is liking the things which she never liked before. Now she is liking the things, suppose she was liking sweets in pre-pregnancy state, now she doesn't want to see sweets this time. She was taking cold drinks a lot in pre-pregnancy state. Now she wants to take hot things. So these type of changes can occur in first trimester. Frequency of micturition is because uterus starts enlarging, and so the bladder is getting irritated, so she wants to pass urine quickly, and she has to go repeated number of times. Heaviness of breast is again very common, as in premenstrual state one feels heaviness. Similar type of heaviness is noted in first 3 months of pregnancy. Any medication has she taken? Because in first trimester we do not advise any medication, because of effect of congenital malformation are maximum in the first trimester. One should not take any medicine. So if she has taken any medicine, you must know the only medicine which is recommended is folic acid in first trimester, or something for nausea or vomiting if it is not controlled. If there is excessive vomiting, it is called hyperemesis gravidarum. If she is not able to retain anything, then she should be hospitalized, which is extremely rare. Now, history of vaginal bleeding is very important in first half of the pregnancy or first trimester, because this is not normal. Till now, which I have discussed, were normal. History of vaginal bleeding and pain in abdomen is not normal. Bleeding in the pain, amenorrhea, pain and bleeding indicates that she is having threatened abortion. But if there is a history of amenorrhea, pain and passage of clots or passage of conceptus, it could be incomplete abortion or complete abortion. Or if there is acute pain, just missed period, collapse, it could be an ectopic pregnancy. So this only you get by detailed history taking. Second half of the pregnancy. Next, amenorrhea continues. Now she feels quickening. As I told you, first kick of the baby is called quickening. After 28 weeks, she feels proper fetal movements. Any history of vaginal bleeding again is abnormal. Now, after 28 weeks, it is called antepartum hemorrhage, which is included in high-risk pregnancy. Cause of this bleeding could be placenta previa or accidental hemorrhage or vasa previa. Swelling over the feet, discomforts and cramps in the muscle. Swelling of the feet is normal towards the end of the pregnancy, that means around after 38 weeks. But it is certainly not common if it occurs at 28 weeks or 30 weeks. And this swelling, if it is increasing and along with swelling she has breathlessness and palpitation, then one should keep in mind that it could be a heart disease with pregnancy, it could be severe anemia with pregnancy. The swelling of the feet and which is increasing, and she complains of headache, vomiting or epigastric pain, it could be preeclamptic toxemia. Then the history of fetal movements again very important, because when fetus is kicking, that means everything is okay in the uterus. But if she does not feel any fetal movements for more than 24 hours, and you must ask sometime directly in question, is she feeling fetal movements? And if she is not feeling fetal movements for more than 24 hours, it should be seen on examination and investigation about the fetal well-being. Next, please. Previous obstetric history is again very important, because if she has previously delivered normal babies, then chances of, and this is a third pregnancy, the chances is that she will have normal delivery this time, which most of the women ask to you that, Doctor Sahab, ye bachcha theek hoga? Agar if she has previous normal deliveries, you can say yes, it should be normal this time also. And you must note down the last delivery when she had and last abortion. Next, please. In the obstetric history, we write in order of number of deliveries she has, the total number of delivery, year and date when she had first delivery, second delivery, third delivery, and so on. Then ask whether it was full term or preterm. If she has 2 preterm previous delivery, chances of this delivery to be preterm are again more than 50%. Then whether she had any antenatal checkup done, and if done, was there any complication in the previous pregnancy? If there was any previous complication in previous pregnancy, like preeclamptic toxemia or diabetes, it can reoccur in this pregnancy also. Then again is what type of labor she had. Labor was normal in duration, labor was normal, and she has normal vaginal delivery, she should have normal delivery this time also. But if there is a history of prolonged labor and difficult labor, then one should assess her from that point of view, that was there any, it is because of the small passage or big passenger like fetus. Where that it is very important to know where the delivery was conducted and who conducted the delivery, whether it was home or hospital. In hospital you get all the records on discharge slip, while it is very difficult to find out when she delivered at home that who conducted and what was the problem. But one can make out certain points by knowing that it was a very difficult delivery, the eye has to extract the baby and baby died. That means she had a difficult vaginal delivery and there was some injuries because of which the baby died. Then how was the preterium? One should know that preterium is the period from delivery till 40 days where the involution takes place, involution of uterus and other organs takes place, which is very important, and it is normal if there is usual complication is fever, mastitis and cystitis. Then ask about the baby. Baby is alive or stillbirth. If alive, what was the weight of the baby? Normal baby weight is 2.5 to 3 kg. What is the sex of baby? Whether baby is completely immunized, and how long the baby was breastfed. Because today's we expect that baby should be put to breast immediately after delivery in cases of normal delivery, and between 4 to 6 hours after cesarean. If the baby was stillbirth, was it fresh stillbirth because of difficult delivery or macerated stillbirth? Next, in the past history one must know history of diabetes. I have already told. I want to emphasize history of rheumatic fever in the past. It is important because it may lead to rheumatic heart disease and the reproductive age group. Heart disease, hypertension, again leads to pregnancy related complications like preeclampsia. History of fits, which is again very important. If she had fits earlier, that means it is a case of epilepsy. While if she had fits for the first time during pregnancy, eclampsia is the first diagnosis. Next, family history. Multiple pregnancy runs usually in the siblings and in the family, and if she is twin pregnancy, ask whether her mother had twin pregnancy or not. Similarly, hypertension, diabetes or genetic disorders, they should be asked because they can affect. Next please. In personal history, history of tobacco and smoking lead to IUGR or premature baby. Next please. Dietary history is very important because normal diet is 2200 to 2400 calories, while during pregnancy 300 kilocalories are added, for especially in the second half of pregnancy. It is very important that she should take not only quality diet but quantity also. This is diet is usually deficient in our ladies, and 80% of ladies, pregnant women having anemia, mild to severe. 20% women from poor socioeconomic status have severe anemia. To sum up the obstetric case, I'll say that take detailed history, and symptoms like breathlessness, edema should be noted because they are abnormal symptoms. Similarly, vomiting, wavered appetite, they are the normal symptoms. Here and there, aches and pains are normal because there is physiological changes which are occurring in the body. So one must be careful in taking the history detail. You can diagnose positively towards a positive definitive diagnosis which can be confirmed with examination. Thank you.
So I will like to thank our expert, Professor Goel, and I hope that all the students who are watching this program, they have learnt very important hints, because history is very important and that can give you very important clues for further diagnosis. So we break here for 15 minutes and we'll come back at 12 o'clock, and then we'll cover how to examine a clinical case of gynae and obstetrics. So please join us after 15 minutes at 12 o'clock. Thank you very much.